So you're all preparing well for the exam on the Monday, right? So I'll not be taking much of your time, I'll not teach anything today. If you have any doubts in your topics for the exam, you could ask me for the next half an hour, so that I can help you with whatever is needed. And next Saturday onwards, I'll continue liver, and I'll try to finish liver. So this has already started with pancreas. So liver, and then probably uske baad gallbladder. These are the things I'm going to continue. How many any doubts you can ask me. I'll be on YouTube live now. Or if you want to just study, you can study. Because I had to come, I came, so don't worry about it. Don't worry about it. Yes. So how is the preparation, everyone? Who is Ajitesh Reddy? Ajitesh Reddy also is there in your batch? Whoa, I did not even know somebody existed with that name. Ajitesh Reddy. Who is he? Who is this one? Any doubts in the exam going subjects, exam going topics, you can ask. I'll try to help. Today I'll not take any class. If you want, I can start liver's class now. 15 of you here. You can tell if you want me to start liver, I'll start it. I have no problem whatsoever. So you can ask and I'll continue, or you can ask doubts about the present exam. That also I can clarify. So we have a new HOD, Dr. Ganesh. You will be seeing him once you come to the college, whenever it opens. If all goes well, you may not see me after you come to the college. Anybody has any doubts? Arteriography, Vaibhavanand. Okay, arteriography is nothing. What you do is, you will select a artery in the superficial system to go to a more deeper system. Usually for cardiac procedures, it is the right radial artery, right femoral artery, followed by left femoral artery and left radial artery. But usually it is the right radial artery. So what happens is, first you identify the artery that you want to cannulate. Then, under the guidance, you will puncture that with the guide, and then you put a guide wire. Okay, you put a guide wire through the right radial artery. If you're trying to cannulate if you want to check the angiogram, coronary angiogram, you will basically pass through the right radial artery, then radial artery to the subclavian artery, then you'll enter the heart. Okay, the vasculature of the heart at the right atrium, and then you will see if you can pass a dye. Then you will pass a dye through the guide wire. You will go there, then you will pass a dye. Once you pass a dye, what happens if the dye passes through all the vasculature at the same time with the same intensity without any narrowing. It is a normal arteriography. But if you see, there is a narrowing anywhere, that is the place where it is occluded. Based on the size of the occlusion, whether it is 70%, 50%, 60%, 90%, or a complete thrombotic occlusion, that is CTO. Okay, CTO, complete thrombotic occlusion. This is usually in your heart. It is not in your other systems. So whenever symptoms will be produced when the artery is blocked at about 70%. So you will stent the vessel when it is blocked 70%. Otherwise, you can give thrombolytic agents and also antiplatelet as well as your lower lipidemic agents, that is statins and fibrates, to decrease the cholesterol level. Thereby you can manage medical management, and you will repeat if it is 60% or less blocked, you will repeat it once in about 3 to 4 years to check if that is progressing to a complete block. Okay, so that is how it is done. And when you want to check about the other vessels, renal arteries, and you want to check the abdominal aorta and all, you will cannulate through the lower limb, that is right femoral artery. Basically it's nothing but you pass a dye through with the guide wire. You pass a dye. If the dye fills well, which means there is no blockage. If it does not fill well and there is narrowing, it is basically a constricted vessel. That is basically arteriography. Similarly, it is the venography also is the same. Is it understood? Bed sores are nothing but is a pressure source. Whenever you have pressure applied at a structure, okay, through the friction of the pressure, there is first erythema that forms. Not just bed sore, anywhere that there is pressure, okay, anywhere there is pressure, and you're putting with the same amount of pressure at the same place for a lot of time, probably 48 hours. The skin will get irritated, the skin will give up by forming an erythema. This erythema, okay, will slowly start causing local inflammatory reaction, and this reaction will tear the skin. Once the skin is gone, it will form a ulcer, and this ulcer, once the breach in the dermis happens, is exposed to your subcutaneous tissue, and once the subcutaneous tissue is there open in a pressure sore, it's only going to get worse because it leak, continuous fat will leak because there is no skin protection. And as it leaks, okay, the bed sores are graded on the amount of destruction that is happening. They are graded in the form of grade 1, 2, 3, 4. Okay, in grade 1 only superficial erythema is there. Grade 2 the skin is breached. Grade 3 is your subcutaneous tissue breach, and once grade 4 either osteomyelitis or the bones are exposed. So it's very difficult to treat grade 4 bed sores. Grade 3 bed sores only with minimal amount of exposed bone. You can apply back therapy or you can do a secondary suturing. There is nothing much of grafts that you can do in bed sores. It's all because the pressure which is being constant will cause irritation at the skin, and once the skin breaches, the dermis as well as the subcutaneous tissue start getting injured, and that will only make the bed sores worse. So venesection and its procedure. Venesection is nothing. It's basically an emergency procedure where you're not finding any vessels and venesection these days has almost become rare. Why? Because now you know the techniques of putting a central arterial line. So venesection has become almost avoidable. Why? Because and usually when it is done, it is done in the burns individuals. It is done in burns individuals. So what you will do is you will when the whole skin is burned, the veins are not clearly visible, so you cannot create a superficial line. So what you will do is you will select the vein that has to be cannulated, and most of the times in burns patients the vein that is cannulated or venesection is done to the saphenous vein at the medial malleolus, just about 1.5 to 2 centimeters or 1 inch, about 1 inch above. What you will do is you will make a skin incision. Okay, you will make a skin incision, and based on the skin incision you will have to identify the saphenous vein. Once you identify the saphenous vein, you pass, okay, in the subcutaneous plane, you pass an artery and then put a wire-like thing to make the vein superficial, okay, only because you have to puncture on one side. You should not puncture on both the sides. Okay, you should puncture not circumferentially, you should only puncture linearly, not linearly, transverse incision on the vessel only at one side, and then you pass a large bore needle if you want to pass a needle, or you can put a big feeding tube, okay, feeding tube, so that through this feeding tube, once you suture, that once you fix this, what you can do is you can continuously flush the patients with enough amount of fluids that is needed in burns patients. So what is the use of venesection is, at least till an expert comes to put a central line, this will be helpful to you to make the patient hemodynamically stable. So the cannula that the vein that we choose is your saphenous vein. What do we write in autoimmune thyroiditis? What all do we write? See, there are about 3 autoimmune thyroiditis that we know. Okay, that is Buddhi thyroiditis, Hashimoto's thyroiditis, and Reedon's thyroiditis. So what happens in this is your body is producing, and Graves' disease of course, your body is producing autoantibodies against your own thyroid cells. Okay, so what happens here? This normal physiology, pathophysiology. So what happens is autoantibodies are produced, and these antibodies will react with your body cells, normal cells, that is thyroid cells or the parafollicle cells, the C cells, whatever. So when they react, what will happen? They start producing antibody-antigen reaction. When this antigen-antibody reactions are produced, what happens is you will have damage to the normal cell. Okay, you will have damage to the normal cell, and once this damage is happening over a period of time, the lymphoid tissue gets deposited, and this lymphoid tissue over a future, in the future, can turn into lymphoma of the thyroid gland. So basically it is autoantibodies that are produced against your follicular cells or parafollicular cells, whatever cells that are there in the in Graves' disease, it's basically it will start producing or secreting T3, T4, T3, T4, thereby causing hyperthyroidism. And in Hashimoto's thyroiditis, it is initially hyperthyroidism, and over a period of time it becomes hypothyroiditis and hypothyroid features, and usually you don't operate in a case of Hashimoto's thyroiditis. Where do you see cricoid aneurysm? I think cricoid aneurysm is something that I told you. Where do you see cricoid aneurysm? If it was not told, probably yes. Where do you see cricoid aneurysm? It was my own class. When do you see cricoid aneurysms? Cricoid aneurysms are basically congenital AV malformations, most commonly seen in the head and neck region. Okay, they are congenital malformations, a group of vessels becoming malformed and then then cause a dilatation. There is sometimes AV fistula. There is an AV fistula that forms, shunting is there, and it appears like a cricoid. That's the reason. Cricoid is nothing but varix. Okay, saphenovarix, a simple single area dilatation of a arteriovenous malformation that appears as a nodule. Okay, basically it can happen in small vessels, it can happen in large vessels, and the vessel walls can be either thick or thin in cricoid aneurysms. La 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 la. Megam premana chipurakai palakettin. How to answer Bun's essay which have certain person of burns. See, whenever a burns question comes, he'll ask you to classify burns. Okay, so what are the different types of burns you guys know of, like flame burns, thermal burns, frostbite, chili beans, electrical burns, and these are the burns that you guys know of. So again, you can classify them. Superficial burns, deep burns, and superficial burns, say first degree burns, second degree burns, third degree burns. You can classify them on that basis, and once you classify the number of what is the weight they give you, so if most of the times it is about 50-60%, so you choose a formula. Okay, you choose a formula, either you choose not Wallace, what is that we use for Parkland's formula. Okay, Parkland's formula, you calculate 4%, 4 into percentage of burns into body weight, and then you have to divide it into two halves, one given in the first 8 hours and then given in the 16 hours, then 16 hours. You can give as much as fluid is there that is given, and then usually what is the fluid that you prefer? Initially it is ring lactate, and once the burn sets in, you will start giving colloids. Blood transfusion also can be given because there is enough blood loss and the patient needs. And what is the food, what is the diet that the patient should be taking, that you will write. And then what are the complications of burns, what are the complications of burns, how do you treat. Then they can ask a special scenario, like if it is in the head and neck region, if it is in the chest wall region, if it is in the this if it is in if it's only in the limbs, then they may ask you what are the contractures, what are the procedures that you do, what is the commonest cause for death in burns immediately, what is the commonest cause of burns death after 24 to 48 hours, and late complication. Late is usually sepsis, earliest is immediately is the neurogenic shock leading to death, especially in the initial asphyxia. Then second is it's going to be hypovolemia. So if you write like this, if you know the subject, I think you can easily write burns, because essay should not be a problem, because essay is always divided into about 3 to 4 subtopics. So each of it you have to see how much it is carrying marks and how much you should be writing. Duplex imaging, it's nothing but how to check the vessel wall, the flow of the blood vessel, okay, the flow of the blood vessel, how is the vessel wall, and you want to know the caliber of the vessel wall. So you will do a B-mode ultrasound or a duplex scan, okay. It is nothing but an ultrasound that picks up the flow, the speed, the velocity, and the flow towards the wall or against the wall. So based on this duplex scan, you can classify the arterial disorders or the venous disorders of the lower limbs, especially if it is DVT, if it is only superficial veins reflux, or whether there is a block in the perforators, when it is artery, if there is a chronic thrombus, if the vessel is thickened, the whole of the vessel wall is thickened, then the vascular flow is, you check for the vascular flow, and thereby if diminished or decreased flow, you will say mono, usually it is basically triphasic flow. Once this vessel starts getting compromised, it will become biphasic, and finally monophasic phase. Monophasic phase ke baad there is nothing left over. Most of the times it is amputation that ends up. So duplex scan is the investigation of choice for venous and arterial occlusion of lower limbs. Can you simplify and explain management of varicose veins? It's too complex in the book. See, varicose veins, why do they come? How do they come and where do they come? People standing for a lot of time. And then it is because of venous hypertension. Venous hypertension. So you have to know what are the causes. Long-standing people, those who stand for a long time, whenever there is inferior vena cava compression, in pregnancy, gravid uterus, or any tumors of the abdomen. These are the reasons for you to develop varicose veins. Varicose veins are again divided into two types, pathological and physiological. Physiological are seen in pregnancy, pathological are seen in multiple disorders with venous hypertension. So what are basically if you have to define varicose veins. Varicose veins are divided by elongated, tortuous, dilated veins of the lower limbs. So varicose veins are more common in the superficial venous system, especially the great saphenous system, followed by short saphenous system. So venous hypertension will lead to formation of dilated veins, and there is venous pooling. Initially there is venous pooling, and this venous pooling will become venous congestion. Then there is transportation of vessels, local irritation that will lead to hemosiderin deposits, and this hemosiderin deposit will cause the thickness of the subcutaneous tissue, loss of the subcutaneous tissue followed by thickness and healing. This will lead to formation of fibrosis, and this fibrosis is called lipodermatosclerosis. And when there is only deposition of hemosiderin, there is depigmentation. As this vein starts, once this skin and the subcutaneous tissue gets thickened, if it gets thickened, one of the reasons for varicose veins is deep vein thrombosis also. So once these gets thickened, you have to understand that the skin is going to heal, ulcerate. Once it ulcerates, it's called as a venous ulcer, and it's basically resting on a vessel. So venous ulcer, and this venous ulcer will keep on growing if you don't attend to it. And the best treatment for varicose veins is applying a Biscard's regime, that is a four-layered dressing of the venous ulcer. So what are the then you will be asked about complications. What are the complications of varicose veins? Varicose veins is first pigmentation, then lipodermatosclerosis, venous ulcer, cubitus deformity, periostitis, and then ultimately, if left for long period of time, it can turn into Marjolin's ulcer. How do you treat? Superficial, that is those that are only having your perforator incompetence. You can do a subfacial ligation of the lower limbs. But if it is if it involves your great saphenous SFJ junction, then you may have to do a flush ligation of your saphenous ring, and then followed by stripping. This is called as Trendelenburg's procedure. These days, basically, newer methods have come, and that is laser surgery. That is nothing but laser surgery, where you can perform laser and remove the vein. And for the lower limb, only superficial veins, that is perforator incompetence, you can get a radiofrequency ablation done. You can do a foam sclerotherapy, and all depends on this. Then there is something called a CEAP classification. In CEAP classification, what is the thing? Initially, C1 is nothing but only reticular veins, or dilated veins of spider nevi less than 1 mm dilatation. Then you have superficial blowouts, that is numbered stage 2. Stage 3 is nothing but your varicose veins that are thick. Then stage 4 is lipodermatosclerosis. Stage 5 is stage 5 is healed ulcer. Stage 6 is active ulcer. Anatomical is if it is superficial system, or it is the superficial perforator system, or the SFJ junction, if it is obstructive, or if it is because of restriction. That is another thing. Then pathological grading is if it is how did it happen. CEAP is how did it happen. Pathological is if it is only regurgitation or obstruction, or both regurgitation plus obstruction. That is pathological grading. I don't think the book is having such difficulty. It is more simpler. Yes, adenoma thyroid is solitary nodule. But solitary thyroid nodule need not be adenoma. It could be a part of a multinodular goiter, it could be a malignancy, it could be anything. But the adenoma thyroid is a single solitary thyroid nodule. Solitary thyroid nodule could be many. It is the most dominant nodule of a multinodular goiter. It could be a malignancy. It could be a simple cyst. See, thyroid crisis occurs when there is when it happens on a OT table, when you have taken a case for thyroidectomy, okay, thyrotoxic crisis you call it as. What happens is you take this patient for surgery unprepared, because with his or her thyroid levels already high and uncontrolled, you take them for surgery. Once you take them for surgery, that is called as thyroid storm, okay. Immediately there is hypersecretion of thyroid gland, that T3, T4, T3, T4 just blow out, and they cause severe hyperthermia, severe tachycardia, malignant hyperthermia, they have tachycardia, they have severe flushing and all. That is thyrotoxic crisis. Thyrotoxicosis. What was the next question? Hyperthyroidism is whenever there is excessive T3, T4 production. Okay. Thyrotoxicosis is seen in autoimmune thyroiditis, that is Graves' disease. That could be primary thyrotoxicosis, secondary. Primary thyrotoxicosis usually have symptoms with your nervous system, and secondary thyrotoxicosis has symptoms of the cardiac system. So simple hyperthyroidism could be overcorrection of hypothyroidism, also can cause hyperthyroidism. Okay, even Hashimoto's thyroiditis initially can cause hyperthyroidism, but that is not thyrotoxicosis. That's not thyrotoxicosis. Thyrotoxicosis is usually because of Graves' disease or secondary thyrotoxicosis. Thyroid crisis, that is also called as thyroid storm. You have to be, you should know what it is. Yes, you have to write all the three. Medullary carcinoma of the thyroid, make it minimal. Why? Because it is not so this thing. But yeah, when men's syndrome is asked, you should write about medullary carcinoma of the thyroid. Actually, it is 4 thyroid malignancies, not 3. There are 4 thyroid malignancies. That is papillary, follicular, medullary carcinoma and anaplastic carcinoma of the thyroid. Yes, all of them have to be written in separate headings. Yes, each of them should be written separate. Why? Because papillary carcinoma, it is lymphatic spread. Follicular carcinoma, it's vascular spread. Medullary carcinoma of the thyroid is lymphatic spread, but the thing is, when medullary carcinoma of the thyroid is there, it is usually associated with pheochromocytoma and other parathyroid problems. So you have to be knowing it. And anaplastic carcinoma of the thyroid, patient comes with stridor and carries extremely poor prognosis. So all of the 4 have to be written. And when you write follicular carcinoma, basically FNAC is not the investigation of choice, because you cannot investigate it easily, because on FNAC follicular cells are there and it is considered as follicular adenoma. Whenever follicular adenoma is suggested, it means you have to operate and then decide whether it is a follicular carcinoma or follicular adenoma. Now usually, Vaibhav, remember, they won't ask you write about thyroid cancer. They may ask you what is classified thyroid malignancies and write in detail about histological features, etiology and factors, investigations and treatment of either papillary cancer, papillary carcinoma, or follicular carcinoma, then medullary carcinoma, as well as anaplastic carcinoma. Anaplastic carcinoma is rarely asked. Differentiated thyroid cancer, what is that? I really don't know what is a differentiated thyroid cancer. Differentiated cancers, I don't think are there in thyroid. They're basically in your bladder, bowel, oral cavity. But I've not heard about differentiated thyroid cancer. Nowhere. Undifferentiated, dedifferentiated. It's because it's there in the plastic and all, not here. Not necessary, but suppression dose of L-thyroxine is important. 2 to 3, 0.2 and 0.3 milligrams of, or 200 to 300 micrograms of L-thyroxine. When you give it in suppression dose for papillary carcinoma of the thyroid, because it is TSH dependent. It should be enough. It should be enough. Unless and until you're asked about suppression dose, you don't have to write dosage. Okay, you guys carry on. We'll see you in the next class. Even I have some preparation to do.